welcome everyone. We are so excited to have you here. This is the presentation being held on Monday, October 4th, Creating a Culture of Innovative Quality Improvement, Tools for Practicing Midwives to Implement at Your Birth Setting. And as you can see, there's quite a few of us who are here to participate tonight, share our different practice settings, the different areas that we work with at Frontier, and the different areas. We all have worked in different birth settings also, which I think is kind of a nice addition to this. So we can hopefully give you some guidance and some help as you try to navigate this. So your faculty are listed here. I will introduce myself. My name is Tia Andrighetti. I am Frontier's Innovation Coach and Simulation Coordinator. The one thing that I don't have officially in that title right now is midwife, but I am still a midwife. And I have Donna Barisic with me, Tanya Belcheff, Vicki Burslem, Maria Mock, Lisa Huckabee, and potentially even Eileen Thrower. I don't know if she's going to be able to make it though. So tonight our objectives are we're going to discuss simulation as a quality improvement technique. We are going to review the new Joint Commission guidelines that are mandating simulation and drills in our birth setting. We're going to review an IP complication simulation, and we actually chose a postpartum hemorrhage one for you all. We're going to discuss fidelity in your birth setting and what fidelity means, and we're going to identify ways to alter the simulation to your birth setting. So my real big goal today is that you leave here with something tangible. So the first question I want to ask is, did everybody see that the handout went out this morning? Print it, have it on your computer. If not, know that it was going out. If you haven't gotten it, you can email me. I have a pretty distinct name. It's tia.andrighetti@frontier.edu. I think I am now the second or third Tia at Frontier system, but there's nobody with Andrighetti or close to that as a last name. So I'm happy to send it to you if you have not gotten it. So we will get it to you. So at first, I want to just tell you a little bit about simulation, what the point of it is. Regardless of when we all went to nursing school or midwifery school, we used simulation. We just might not have called it simulation. We might not have called it high fidelity simulation, but we all practiced on each other. I can remember as a BSN student, laying in a bed. This is back still when BSN students were expected to learn how to make an occupied bed versus an unoccupied bed. I remember laying in the bed so my partner that day in lab could roll me around and make an occupied bed with me. And so if we think about it, we probably practiced injections on each other. Some of us that went to Frontier, we practiced pelvic exams on each other. So we were simulating all of those things. It is now a huge business that has a huge evidence base. And what we know is that it allows us to practice things that happen infrequently, but that can have very dire consequences for our patients. So practicing, I wish postpartum hemorrhage happened extremely infrequently. It doesn't, but practicing it to where you need to activate the OR team or do a mass transfusion does not happen all that frequently in places. So this allows us to do things of that nature. Potentially, you could simulate a patient who's having eclamptic seizures. And of course, we hope that doesn't happen frequently, but can have very dire consequences. So it can help us learn about the issues that we have in our birth settings that make the situation go less than ideally. So the point of these, and if you're versed on the simulation literature, these are called in situ simulations. So we want you to do them not in a simulation center. We want them to do them on your birth setting, wherever that may be, whether it's a home birth, hospital birth, out of hospital birth, birth center type of setting. do whatever you normally do so that you can learn what are the sticking points, what are the areas that maybe could use some process improvement. The literature does support that it increases teamwork and communication during the crises. And for all of us that have seen the reports over the last 20 years, we know that communication is one of the most common reasons why a crisis does not get handled correctly. And it does help us keep our skills up to date. So for some of us who've gone to midwifery school just a few minutes ago, it takes a lot to keep up with the evidence base that's out there, to keep up honing and refining our skills. So if being forced to practice them, the evidence does show means it's safe for the patients and we are able to perform better during a crisis. So these are the guidelines that I was alluding to. The Joint Commission has put out a report, and I want you to notice this date, August 21st, 2019. How many people have heard about this report that mandates postpartum hemorrhage and maternal hypertensive drills? Yeah, I'm seeing some heads nodding. I hadn't heard of it either. Now, I think COVID has delayed their mandate, but the latest guidance I have seen, because at first, if you notice down here, it said they must do these after July 1st, 2020. So that was their due date. They have now, it seems, extended that. Guess when it is, everybody? 2.5 months from now. By December 31st of this year, all of your birth settings have been mandated by the Joint Commission. And if you scroll down and follow that link in the PowerPoint, it will tell you that you have to drill postpartum hemorrhage with all of the usual, I don't know if they use characters, but I'll use characters, that would be there in your birth setting. So if you're in an out-of-hospital birth setting, and EMS is part of your protocol for handling a postpartum hemorrhage, now this precludes that you care what the Joint Commission says. I don't know as in they mandate as much in birth centers, but obviously hospitals, they do. So just be aware of this. So that means in hospitals, anesthesia needs to be part of this discussion, the OR team, the lab, who else can we think of? The blood bank, all of those people need to be participating in these drills so that you can determine if there is some sort of issue. And it gives the requirement, their rationale, and the references they are basing this on. Just so you know, I believe I included, so this is not just postpartum hemorrhage, but they also, oh, I can't tell, scrolling too fast. Yes, so they also require this for maternal hypertensive crises. So hemorrhage and maternal hypertension. So I just wanted to highlight number 5, that says conduct drills at least annually to determine system issues as part of ongoing quality improvement efforts. Drills include representation from each discipline identifying the organization's hemorrhage response procedure, include a team debrief after the drill. So hopefully you're seeing this is no longer a suggestion. You actually need to continue doing this. So I want to take you now to the simulation that you all hopefully should have gotten. And I want to walk you through this simulation. So when I got my doctorate, I had the pleasure, I live in New Hampshire, of working with Concord Hospital at that point in Concord, New Hampshire. And they were just building a simulation lab. And the 2 people that headed up that simulation lab were I want to say it was a intensivist from the ICU unit and an emergency room nurse. So when I came along and I said, oh, I would love to do some clinical hours with you and I want to do birth, they were thrilled because, as you all know, those 2 specialties really want nothing to do with people who are pregnant and are very afraid of that. So I spent some time creating these multidisciplinary drills for their labor and delivery unit, and then the family practice doc who ran the Dartmouth family practice at Concord Hospital got wind. And so then we included the family practice residents in these simulations also. So it was lots of fun. So I've included a supply list. I highly recommend the Mama Natalie mannequin. It is actually a strap-on mannequin that can simulate the maternal abdomen and vagina, and it straps onto a real live person. Last I knew, they were about $1,000, which is a lot of money, and I get that for a lot of birth settings, but they are way cheaper than many of the big mannequins that, you know, obviously can talk and have vital signs and things like that. It comes with a placenta, but if you don't have something like Mommy Natalie, you want a placenta with a cord attached, you want some sort of baby, you want your birthing room. So you want to do this in one of the rooms you use typically for birth. Because again, part of this is determining what are the sticking points or what are the areas where things aren't going as smoothly. You want some sort of light source, a delivery table with all of the usual suspects of delivery supplies, some sort of foam soccer-sized ball. And this helps to simulate a contracted uterus. As we did today on campus, you can also use your fist. So in the Mama Natalie, you can put your fist in there and it can feel like a contracted uterus. You want to have some sort of simulated medications. And this is an area I will tell you that will get extremely tricky in hospital settings, because you have to bring in the pharmacy if you have a Pyxis type of system, or you have to have them set up, and do not make them look anything like real medications. This is a huge area of error. So you wouldn't want to use a empty vial of any of these. You'd want to make some sort of little box or some sort of something that says the medication name, so that so that there's no medication in there, nothing that somebody could potentially feel like they inserted a syringe into, got some sort of dose and gave it to a patient, and really there was nothing in there. If, you know, part of what you're going to see in the Joint Commission document is they are going to require that every unit has a postpartum hemorrhage kit. So in some ways that's nice. It's nice for the patient that the medications will all be there. Hemabate can sometimes be a little sticky. It is kept in a refrigerator. It can be out for a while, but where does Hemabate fit into that that toolkit, I think, is still a little bit unclear. And so the other medications you're going to have in there, we like either sitz bath or enema bags to put the hemorrhage in. And we'll talk more about that after. You'd want some sort of bucket to collect the blood. You want either some heavy duty clothespins or the snack bag clips that are really tight ones, not those loosey-goosey ones. Because what you're going to do is you're going to fill the sitz bath or enema bags, and then you're going to roll down the top several times and put those clips on it, because you need to put them under pressure to get that gush of blood when you're simulating this. And so the top needs to be really well closed. You're going to need the supplies that you need to make the blood, and we've included a recipe for blood at the end of this. You want a pitcher to fill the bags and a funnel in order to get the blood into the bags. You want some sort of woman to play the patient. So that would be our standardized patient. She's your simulated patient. She's taking on the characteristics of a real live patient, and is going to be someone that the people managing the crisis have to interact with and deal with. Ideally, you'd have another person who could play her support person. If no one else is available to do that, then what I'd say is just alter the sims to say why she doesn't have a support person. It's nice to have someone to play the nurse, who knows what's going on, because they can give the team a SBAR report as the team arrives to manage this complication. You, of course, want other people, including nurses, to arrive to manage this situation, but having someone who can help you set up and break this down, and who can, kind of be in the know that this is happening, is extremely helpful, because this is a fair amount of work to undertake. We've given you blow-by-blow instructions of how to set up the bed, what to do with IVs and things like that, how to fill the bags, all of that information here. The next part I want to cover is the pre-brief. And this is very important to do to help explain to everyone on the unit what's going to happen. Now, one of the first decisions you're going to have to make is this going to be a known simulation happening, telling everybody this is going to happen on Tuesday at 1 p.m., or are you going to activate some sort of crisis team, or some sort of, whether you have a code word that goes out in your birth setting, you pull a button on the wall, something like that, and have it be the surprise. If that's the case, you would want to make sure sometime prior to that happening, you give everybody a pre-brief of what is going to happen. This is where you're going to introduce the concept of simulation to everyone. You're going to emphasize that this is for practice, and the point is to help the unit get better and the team get better at managing the complication. The point is not to place blame or point fingers or things like that. You're going to explain what the objectives of the simulation are, and I'll show you those in a minute, and establish this as a safe environment where everybody's coming together to do their best to learn and to improve the management of this complication on the unit. So you really want to set up that safe environment, because this can be very vulnerable, whether you've been practicing for a very long time or are a student or learner in this environment. You also want to emphasize that they should manage the care of the patient through until mom and baby are both safe and stable. And this is where we're going to talk about combining some simulations too. You want to try to encourage everybody to take on this as much as they possibly can. So you want them to get into it and play their roles. You don't want them to just say, well, I would get Pitocin, or I'd give her Hemabate. What is the dose of Hemabate? Actually go and get the medication, simulate drawing it up, and then simulate giving it. So some objectives of this simulation could be, and you can alter these depending on your unit, the staff will communicate effectively during the simulation using SBAR and closed loop communication. Those are both two communication tools from Team Steps. If you're not familiar with them and you Google Team Steps, you can go to the AHRQ website and you will learn more than you probably ever wanted to know about both of those types of communication. The staff will communicate effectively with the patient and significant others, and they're going to work together as a team. If you have other objectives, you can add them in there. I would suggest not having more than 3 to 5. Otherwise, then there gets to be too much you're trying to accomplish at one time. We have given you 3 scenarios here that you can use, and we've written out the SBARs for all 3 of them. Notice that 1 is a 3rd stage hemorrhage, 1 is a 4th stage hemorrhage, and the 3rd is a 4th stage hemorrhage where they have to realize that it is from sulcal tears, that it's not from atony, whereas the 2nd scenario is from atony. We're going to then, I gave you a bunch of things that observers can observe for during the simulation so that you can bring up and discuss them during debriefing. And then I give you a bunch of debriefing things to talk about and how to orient them to debriefing. And we're going to talk about debriefing a little bit more afterwards. Here's your fake blood recipe. So I know. So Fidelity is making something as lifelike as possible. So this is where you keep things where they normally are located on the unit. So don't bring them in the room in anticipation of this hemorrhage drill happening. Keep them where they are so that people have to go get them, and they simulate the time that would normally be taken during this, including all of the departments that are normally included in a hemorrhage drill or in a true hemorrhage. It helps increase the lifelikeness of this. And of course, the person who's playing the mother, especially if you can get somebody who enjoys the drama aspect of this, can really make this as lifelike as possible. So just a little bit about debriefing. Debriefing is where the real learning occurs. It's where you make meaning of what exactly happened during the simulation. So if your simulation is planned to take 20 minutes, half an hour, plan that your debriefing should be 1 to 2 times as long as that. So if it's a half an hour simulation, you should debrief for 30 to 60 minutes afterwards. This should happen in a separate space than where the simulation occurred, ideally sitting all around in a circle, so there's no hierarchy of who's talking or who's participating. You should debrief all departments together. So everybody should be there. So this might need to be quite a large room if you can think of it. And remind everybody the goal of this process is to review what happened, not to lay blame to any one person, one department, things like this. Ideally, you would conduct your debriefing with somebody who's experienced or trained in debriefing, and there is a tremendous amount of literature, and there's quite a few courses on debriefing. It really is an art, and it does take a while to get comfortable with this. I have included that sheet that gives you some of the high points and things like that, but it is not something that you should consider lightly. So I'm going to show you a very short video of this happening. For those of you that recognize this, this is from Hayden, so we weren't able to record one on our new campus. So this was from a while ago of what it looks like. And this is a very small exam room instead of a hospital room. So let me just share my stuff.
Long labor, huh? Yeah, long day. Yeah. Okay, let's just see. Let's just see what's going on. I'm gonna have you lay back for me. Oh. Yeah. No, it's in the bucket. Okay. What's that about?
Good.
Feel like you're cramping a little bit?
Yeah.
Yeah.
I feel I was bleeding quite a bit. Is that normal?
Yeah, we'll just kind of check it out here, but yeah, it's a little more than normal. So we have an IV running. Let's give her some Pitocin in her IV.
Okay.
And we'll do 20 units in that IV.
Okay.
Just gonna rub on your tummy. I know it's real uncomfortable. I apologize.
It's kind of scary.
Yeah, we'll get it. We'll get it here. What are you giving her? Some Pitocin. Just medicine to help clamp down the uterus so it stops secreting.
Is that normal?
Yeah.
Pitocin's in.
Thank you.
A little bit dizzy.
Yeah.
Is that okay?
It is. What are her vital signs?
Her vitals have been good. Her pressure's 110/60.
Okay. I can lay her head back a little bit.
Okay.
Gender.
Oh.
Right here. Yours feels like it's thinking about firming up. Take these gathers off there for you.
Oh. Oh.
Yeah. Right there.
I just feel very crampy.
Mm-hmm.
Oh.
All right, let's move to some methergin. I've already grabbed her some methadone point too.
Is that like medicine?
Yeah, we're gonna give you some more medicine to help the uterus really clamp. This medicine kind of makes you have more contractions than helps the uterus, but it stops in between, gives you contraction stops.
Okay.
This medicine will go and it's a shot in your leg.
Okay.
It'll help that uterus really clamp down. Okay.
So I am going to stop that for the sake of our timing here so that we can get to the good part of the discussion. I don't know if you could hear it, but there was the dripping of the blood in the background. And for those of us who have been around a few hemorrhages or two, we know that's an ominous sign when you can hear the blood dripping off the side of the bed and what that might mean for the woman. So what I'm going to do in just a moment is I'm going to send you all to some breakout rooms with the faculty. And I would love for you, and I'm going to keep this slide up here, is I want you to answer these questions and talk about these questions. So what stakeholders do you need to get permission from or to have participate in planning for this event? What learners or staff do you anticipate participating? Who do you have? Who can help you? Because you're the midwives. Are there other people that you can enlist? Are there nurse educators? Are there other providers that you can help enlist to participate to do this? Who's going to set up and break down all the rooms? How are the staff going to be called to the event? Are you going to do this on one shift or move it through all shifts? How are you going to access those medications? And are you going to be able to put them in a Pyxis? Or are you going to have them in a cart in the room? And who do you have to talk to about having these fake medications there? And where are you going to debrief and who's going to debrief? And so what I'm going to ask you to do is that as you go to the breakout rooms, be thinking about and writing down those answers. And then what I want you to do is talk to each other in your room. You all have great expertise in which to troubleshoot how an area that you might find is a sticking point for you in your birth setting, and maybe another colleague of yours here has a way that they're going to try to meet that challenge, or they've met that challenge in the past. So you'll have faculty members in there too who can help you also with that expertise, and I'll be bebopping between the rooms too. So give me just 1 second. In the meantime, if you have any questions, please open your microphone. The faculty can hopefully help you answer those while I'm getting the breakout rooms set up. And if not, we'll get them answered either in the breakout rooms or afterwards.
You mentioned something while you're getting that set up about the blood dripping. The way we make it work effectively is, we have our bucket, and then if you have the type of clip that has the holes in it, so that we funnel the tube through that, and you have control over it, so it's not going to be at the bottom of the bucket, and then you just make sure you position it so that when you're kind of before the people come in, you make sure it makes noise. And the other thing I do is make sure that I like 2 bags because it makes more sound and more rapid release of the fake blood, which simulates the actual hemorrhage better than 1 bag. And then I tell the standardized patients, or if I'm doing it myself, I put my elbows on it to really try to push the blood out.
So Tia, will we come back to this room afterwards, or this will be the end?
Nope, you will come back to this room at the end, and we're going to answer any questions, and people can share some takeaways that they might have, things like that. So please still come back so that we can make sure and get everybody's questions answered. Back, we had some breakout sessions, and then we're going to just take questions, and we're going to have a discussion for the last 10 minutes. That's fabulous. I could go back to the slide presentation, but really the last slide says, what questions do you all still have? What takeaways do you have? Was there something from your room that was kind of really stood out or revolutionary to you? Please, please, please share with your colleagues here in the last 10 minutes.
Nana, why don't you share from our room some of the things that we came up with that are actually more questions or thoughts?
Well, I think when we asked about stakeholders, one of the participants was talking that she's in a birth center, and she was saying that she was trying to engage the community paramedics and EMS, and she went to the chief of police, the fire chief, and even some of the husbands of her staff who were firefighters, and she couldn't get buy-in from them.
Oh, that's so hard.
And that was really challenging. And she said, I don't know what their obstacle was, or, you know, there's somebody raised their hand.
Yeah,
As
Julia.
a child of a paramedic and firefighters and a wife of a firefighter, I will tell you it's the vagina. I don't understand it, but oh my gosh, the OB calls are like their worst nightmare. They would rather have like some sort of brain matter smattered all over the highway than someone who might possibly maybe have a baby coming out of her vagina. So it's really, really hard.
Yeah.
But finding the right person and finding maybe not the chief of the fire department. Most fire departments and the EMS stuff is together, but there's usually a like an EMS chief, and that's who in theory you want to go to. And that may be a little harder to find as far as like going on their website or whatever, but
Right.
anyone wants to chat about that, I would be happy to.
Our birth center had some luck by offering them to do some normal birth training too. So, you know, teaching skin to skin and keeping the placenta in and all of that while they're doing transport, and that engaged them a little bit enough to have them come to do some other things with us.
We had some luck with talking to, I mean, depending on the emergency, you know, there's not time sometimes, but chatting with the ones that actually respond to our, you know, when we call them, and just being like, hey, we'd love to like do some things. Here's my contact info. Like once we're done here, you know, call me.
We offered the local police and EMS when they were out and about during the night, they saw cars in our parking lot to feel free to come in and have coffee. And they all departments that I know of have a medical director. You can always go to the medical director and get some buy-in from them.
That's a great suggestion. I would also say
Great.
maybe it's a different perspective. Maybe you need to talk about how scary it is and come from that perspective and say, hey, we want to make it less scary by giving you some tools that are really practical for you to use. Because I agree with you, Julia. Just like the ER and the ICU, they want nothing to do with the babies and anything coming out of anything of somebody who's pregnant. And so it is very, very terrifying to them. So playing into that piece of it and how you can help it be less terrifying might be a better way than saying, hey, you know, we all need to practice these skills, things like that. But I also like, you know, the offers of coffee and talking to different people too, whatever can get you in the door, to be honest with you.
It seems like as most of the issues surrounding us, normalizing, everything's about normalizing the situation, right? Just bringing to them that it's gonna happen sometime and it's okay, it's normal. You just have to be able to process the information and perhaps catch the baby. It's make it seem more natural. Although, you know, as Julie was mentioning that her husband is a firefighter and sometimes it's that they are afraid of vaginas, but which I agree. but if you just make them understand that it's so physiological and we can do it, right?
Betsy brought out a really good point talking about staffing. And like if somebody's assigned as the rapid response team, they need to be then, there needs to be that awareness of the people that are involved. And we also talked about the COVID fatigue.
Yeah.
This is going to be a hit to be saying, oh, by the way, not only do you have to do all this, this, and this, and take care of da, 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 by the way, we're mandating another thing. And, that's going to be interesting to see for those that are not doing, but I think most places are doing drills, don't you? I don't know.
We talked about it. I mean, this has been their suggestion for the last, at least, I found evidence in 2010. So it's been Joint Commission's recommendation, highly suggested, no specific drills, but the fact that we should be, drilling these types of things, it's just now coming out at a mandate. So, what do we say? It takes about 20 years from the evidence to practice, and we're at almost 12. So we may be a little bit ahead of the curve there, but still a very long time to get it into play with most places.
The birth center, National Association of Birth Centers, I don't even know what it's called anymore, but to be
AABC.
to be accredited, even back in the 90s, we had to do drills. So
Correct.
I think that's something that the birth centers are a little more used to.
Ahead of the curve. Yep.
Yeah, because things don't happen as a rule there because you're so careful to have low risk patients.
Well, and you have to, have protocols and drills of including EMS and what happens in a transfer, and depending on what level of transfer it is to how emergent it needs to be. So absolutely, there's a lot of things to drill with a birth center in addition to it, because there's not an OR down the hall, and there's not anesthesia down the hall, and or the providers to do the things that need to be done in ORs, things like that. So
back to the EMS, Tia, as a midwife in the hospital, if you have student EMS, we can start as the students, because what do they usually do? They stand in the corner somewhere until somebody's ready to deliver. And I used to tell them, if you haven't been in with my patient during her labor, you're not going in to gawk. But you can take that opportunity to say, what's the most important thing for you as an EMS to know? Go in there and find out how to palpate contractions. Know what normal labor is like. That takes a fear. So we can start as the EMS students, not wait till they're on the road, because they've already got their biases by then.
And maybe they'll be less afraid at that point then too, Sheila, because they'll have had more exposure. They'll be able to, we can all read a woman. We know without doing a vaginal exam when she's getting very close to giving birth, and helping them understand some of those signs and symptoms so that it's less terrifying of, oh dear God, I'm going to lift up a blanket and, what am I going to find and how am I going to do this? And maybe we can just help start them then too. So any last thoughts? We're coming down to our last few minutes here, and I want to be very mindful of everybody's time.
One of the topics our group talked about as far as I'd like to see in the future is preeclampsia. Then we ran out of time, but preeclampsia was one that, especially somebody in eclampsia, that how to manage that. So that might be a future thought for your institutions. Develop that
well, that is mandated by the Joint Commission. That is
the high blood pressure, right?
Correct. Yeah. That is the hypertensive crises that they're talking about.
Yeah.
Because of course that is what does harm and kill women still also. So they have already mandated that. So be aware of that. If your units aren't doing those types of drills, also they need to add those in.
Theo, there was one other question in our group about if it was appropriate for someone participating in the simulation to then be the person running the debrief, or if it needed to be an observer. And what are your thoughts on that as the expert?
Ideally, it would be somebody who's observing. what I can say is if we've all done it, where we've participated in the simulation and still led the debriefing, you get a different outlook on things when you're truly only there to observe and don't have a role on it. And so you can jot notes, you can bring up particular points that you want to question the team about, what were you thinking during this particular juncture that led you down this path that you may totally miss if you're either playing the patient or playing one of the providers in that simulation. So ideally you would not, but we know sometimes things have to be done less than ideally to get them done. So
yeah. The other thing that I came out in our group that seemed to be a really good idea was involving the QA committee.
Absolutely.
And which oftentimes, they are involved with the results of codes and getting reports of, and then having to go through and determine if there were ways that the code could have been improved. But I'm guessing that with these simulations, that might be a good avenue to get the QA committee involved, and they can help with, as you said, it's just for feedback, it's not for blame, but how each person could be doing it better. I know that at Brigham and Women's Hospital in Boston, there is a stellar physician. She's been an OBGYN for mostly GYN for 35 years, but she is leaving her position. She's going to only work in the labor and delivery with the residents and the staff to try to minimize complications and, in the delivery and postpartum.
That's fabulous.
And I had never heard of that before. I'm sure it's happened in other places, but here she's got so much wisdom, and she's going to be helping to groom people to reduce the complications, for patients that come in. And that also seems like a really good strategy.
That sounds fabulous. And I'm sure she's well respected, so that can help with buy-in of a lot of stakeholders in things that she may develop. But I love your point of involving the quality assurance people. These are the people, the bottom line people. How much did we get sued because of some poor outcome? And they can mandate things to physicians on top of it because of the need for improvement. And they're also the people that might be very interested to know that a lot of malpractice insurers will give them a discount if they can show regular drilling of their constituents. And so if you have not thought about that aspect, hospitals and stakeholders might be very interested to hear that also, so that they can pay less liability insurance for their providers who are there. Or if you're in private practice, you can pay less liability insurance too. So. Well, I thank you all so much for joining us tonight. I really appreciate this. Thank you to all the faculty who participated in the rooms. I hope you got a lot of your questions answered. I'm sure it has also stimulated a lot of other ones. Please do not hesitate if there's something I can do, or you need me to put you in contact with one of the faculty. My guess is they'd be willing to have a email exchange with you or a conversation to help move you forward on your realm of getting these implemented at your birth institutions. But we thank you. We thank you for your commitment to Frontier. Whether you went here or precepting or just joining us for Midwifery Week, we thank you very much for joining.